This week on the BackTable Podcast.
One of my local guys who always comes up with great ideas, Channing Wiles, said, why don't you tighten the per close before you put the repositioning sheath in? And I was like, light bulb went off. So I did it. And I just take one of the knot pushers from the per close, push the knot down, and then push the repositioning sheath in. Problem solved. I have not had a bleeding issue since then. It works like a charm. And you don't lock the knot, so you can still use the per close when you pull it out, but it just tightens it enough and it solved that problem for me.
All right, we are so excited about our first series of the BackTable Podcast with Interventional Cardiology. I have a fantastic guest today, Dr. Jason Wollmuth. We call him the legend here. He's the one who created many techniques, but he is most famous for the single access, large bore access technique, and we thought he would be a perfect candidate for discussing the topic of large bore access and closure. Good morning, Jason.
Hi, good morning. How are you?
Very good. How are you?
Good. Thanks for having me.
My pleasure. I'd love for you to share with us what you do and where you're at and your background.
You bet. So I'm an interventional cardiologist in Portland, Oregon. I started kind of in the complex PCI realm. I was probably been about 13, 14 years ago when I started learning CTOs. I was in a small town in Oregon where I started right out of fellowship and kind of got my feet wet, was getting, more comfortable doing some of the more complex procedures at that time, but had the opportunity to go learn how to do chronic total occlusion intervention from some good friends, Steve Cook and Bill Lombardi. And that was kind of my entry into complex PCI. And then it kind of grew from there. Being the CTO operator, your colleagues turn to you for other complex PCIs, multivessel disease, left main disease, low EF patients. And that led me to get into hemodynamic support cases, which I started doing about a decade ago. And, there was a lot of fear when I first started with large bore, putting a, 15, 16, 17 French Impella sheath in is a little different than putting a 6 French or 7 French radial sheath in. And so I started doing that. There was a lot of fear of access and complications, but that's something that I was able to pick up relatively quickly. And then, obviously I saw the kind of the dramatic impact on using hemodynamic support in some of my early cases and kind of realized my world had changed at that point. And so became very interested in the use of hemodynamic support and large bore access to do complex PCI cases that, previously were not able to be done at all. And so it really opened a new world for us.
Fantastic. I mean, you just mentioned something that a lot of cardiologists are transitioning into right now, moving from radial access to the large bore, scary access. So obviously this took you quite some time to kind of get comfortable with it. We're going to be kind of delving into that topic today and trying to make things easy for both the people who have not done large bore yet and also some techniques for the experts and the people who practice it every day. So first of all, I thought I would start with the definition of large bore. What do you think is large bore?
I think it's probably anything bigger than what you would routinely use for coronary intervention. So I know when I was, I may be dating myself here, but when I was in my training, we did mostly femoral, and it was mostly 8 French for interventions. So that to me didn't seem like large bore, but when you start getting into balloon pumps, 9 French, and then getting bigger, obviously with Impella and obviously with our structural colleagues TAVR and other things like that. That's when we're talking anything over 9, 10 French. That's kind of what I would consider large bore. But from a interventional coronary interventionist standpoint, really it's anything bigger than an 8 French sheath is what I would consider a large bore.
And in terms of, let's kind of walk through the process. Now you have a case, it's not a cardiogenic shock, it's a complex PCI case where you think you need support and you're thinking, okay, can I place a large bore? Walk us through how you prepare for the case from an imaging standpoint.
Yeah, it's interesting. And I think it's very individual based on the particular patient. Sometimes we'll have femoral angiograms from prior cases, or we'll have CT scans that have been done. It's not uncommon for these patients to have had, CT scans that give you a sense of if there's any vascular disease. So a lot of times you kind of know up front. You don't necessarily need to do, pre-procedure imaging because you've had it looked at in the past. Honestly, when I go do a consult on somebody that needs a high-risk PCI, I'm not a big physical exam guy necessarily. I'm an interventional cardiologist. We look at echoes to as opposed to physical exam, but I actually do a physical exam on them, and I look at their femoral pulses, and if they've got a large bounding femoral pulse and they don't have any bruits, the chances that you're not going to be able to get a large bore in, an Impella in, is pretty low. But in cases where the patient has a history of vascular disease, if they have a history of claudication at all, those are cases where we'll typically do pre-procedure imaging, and typically we use CAT scans for that. Obviously if they have significant renal insufficiency, that's something we need to be aware of, and occasionally we'll just do an ultrasound to get a sense of that. But then the other thing I'll do is when they get down to the cath lab, obviously we're doing ultrasound guided access. I will scan up and down on the femoral artery and look for any evidence of disease there. And those are kind of all my clues as to whether I'm going to need to do more advanced imaging before the procedure. I would say that the majority of cases we actually don't. If they've either got previous exams that we can look at and glean information from, or by physical exam and history, there's no real strong indication that they have vascular disease. We'll oftentimes just get access and take a picture. Certainly before we put any large bore access in, we take a picture because that helps us to kind of plan not only for getting the device in and getting the device out, but also managing it while the device is in and trying to pre-plan for limb ischemia if that's going to be a risk.
From that standpoint, in renal patients, you mentioned a couple of alternatives. Does a non-contrast CT help if they had it from the abdomen 2 years ago? Would you look at that?
Absolutely, we'll look at it because you get a general sense of vessel size, and you're going to see calcification and know whether there's significant disease. If they've got a decent sized artery and there's no calcification there, I think the chances that they're going to have anything obstructive is going to be extremely small. And if people don't have vascular disease, it's very rare to have arteries that are less than 6 millimeters that are going to potentially lead to ischemia unless it's a particularly small person.
And of course, these days, it's almost rare to find someone without calcification. So calcification don't turn you away from a case, but of course, you would probably prepare for it. And you mentioned duplex arterial ultrasound. I find it very helpful in my practice, the velocities and the waveforms in the common femoral arteries, plus the size. And you look at the actual images, it gives you tons of information. In terms of when you said we take a picture, would you take a picture through the access or you put a pigtail up in the aorta? Tell me how you do it.
Yeah, typically what I'll do is I'll get access with a micropuncture kit. I think that's fairly standard nowadays. I think there's reasonable data now that shows that micropuncture access leads to a little bit lower risk of complications. And so that's a standard part of our practice. And oftentimes I'll do a quick angiogram just through the micropuncture sheath. It's a 4 French sheath. It's enough to kind of get you a good sense of at least the external iliac artery and the common femoral artery. And if you don't see any significant abnormalities there, you're usually good at that point. The other thing that's real helpful with that, and the reason I'll do that sometimes, occasionally I'll also put just a 6 French sheath in and then take a picture through a 6 French sheath. But a lot of times if you take a picture through the micropuncture sheath, and the artery looks small, looks diseased, and you think, hey, maybe I want to check out the other side, there's not usually a huge penalty in just taking that 4 French sheath out and holding pressure for 5 minutes and going to the other side. Or you can put a 5 or 6 French sheath in and go up and over and take a picture of the other side if you're thinking that you're going to need to use the other side. And so that's not an unreasonable approach as well. But a lot of times what I'll do is I'll take a picture of the micropuncture sheath, and you get a general sense of vessel size at that point as well. And you can make a quick determination just based kind of on your gestalt about how big that vessel is. What are the chances that big Impella sheath is going to be potentially occlusive? And so one of the things that's the biggest challenge is when you're dealing with somebody that's got some limb ischemia at the end of the procedure is getting access antegrade to put an antegrade perfusion catheter in. And so a lot of times what I'll do is if the artery looks, just based on my quick kind of visualization, looks on the small side, before I do anything else, I'll take
precise? Tell us what's
6 millimeters or less.
okay.
And again, I'm not doing
Right.
actual measurements. I've been doing this long enough. I kind of get a general gestalt of the vessel size. But if it looks on the smaller side, before I do anything else, I'll take my micropuncture needle and I'll access the common femoral artery with the micropuncture access needle, and then I'll put the wire in antegrade and get it down the SFA. So one of the things that's challenging when you're trying to do this when a large bore sheath is in there and it's occlusive is the artery's smaller because it's not getting antegrade flow. And you've got this big bulky sheath there in front of your access point. So there's virtually no way to stick the common femoral artery. So then you end up sticking down below, and oftentimes you get into the profunda artery. It's really hard to ultrasound because the Impella's in the way. And so your stick is often, a third of the way down the femoral artery. And then when you put your sheath in, your sheath's, halfway down the femoral artery. And so now you've got this big dead space where you've got a little bit higher risk of thrombus forming. And so what I like to do is if the artery looks small, before I do anything else, I stick antegrade and I put the micropuncture wire in. This gives me the advantage of several things. One is I can get the stick right over the femoral head. So when I'm taking it out, it's pretty easy just to manually compress that over the femoral head. You're not pushing over, the thigh where you have a higher risk of hematoma formation. The second thing is your antegrade perfusion sheath is not so far down the vessel, so you lessen that amount of dead space and lower the risk of thrombus formation potentially happening. And most importantly, you've got your wire there, and it's easy to get into if you need to put an antegrade perfusion sheath in at the end of the case. You're not battling trying to work around the Impella. And so what I do is I stick it with the needle, I put the micropuncture wire in, I confirm that it's in the SFA, I pull the needle out and I just leave the wire dangling out of the body. And that's all I do. And then I put my large bore sheath in and I get to work. At the end of the case, I then do imaging. It's kind of a rule in the cath lab. Nobody leaves the cath lab without assessing for ischemia and bleeding, obviously. And so we assess at that point. If it's occlusive, I've got a wire in. I just slide a sheath over that wire and we're ready to hook up for antegrade perfusion.
These are such amazing tips and tricks. I mean, you just mitigated 4 or 5 major problems by doing that. The technical difficulty of getting antegrade access, the fact that you're not really losing anything by putting just an 018 wire into the artery. You're sticking the common femoral artery, avoiding bleeding, hematomas, you're avoiding dead space. I mean, this is fantastic. Now, one of the difficulties, especially with cardiologists who don't do vascular interventions, the difficulty of antegrade access, it's a little odd and strange, right? Like a lot of people feel uncomfortable with that. Now, you mentioned that you would stick the common femoral artery and you would wire the SFA. As you know, a lot of times the wire goes into the profunda. And any tips and tricks on how to avoid that? And because if you do it under fluoroscopy, you end up fluoring your hand for a while and, it's not pleasant.
Yeah, I think the biggest challenge is when you're working with bigger patients because oftentimes the body habit is pannus, makes your access entry very steep, and it makes it real hard to get in over the common femoral artery. And sometimes you just have to go down the leg a little bit and you'll end up hitting in the SFA. But that can be a real challenge. And it's one of the reasons why it's a lot easier to do before an Impella sheath's in because you can actually use an ultrasound and see it a lot better. So what I'll try to do is kind of scan up and down the femoral artery and kind of get a sense of where the bifurcation is. That way, before I go on X-ray, I've got a good sense of where, what are the risks that I'm going to hit the profunda. Because, you can, if you hit the common femoral, you can always pull your wire up and try to redirect it down the SFA. If you hit the profunda, you're in the profunda, so you're going to have to restick. So having an ultrasound just kind of get a general sense of where the bifurcation is can be quite helpful. And generally, you kind of know right away if you're in the profunda because it starts taking a course that doesn't look normal. And the SFA doesn't really have any branches off of it. So if it's going down the leg, it's in the SFA. So that's kind of what I'll do is just use ultrasound to kind of get a general sense of where the bifurcation is. And then, we try to do most of the sticking with ultrasound and not under X-ray. Once we hit it, I'll put the wire in and then I throw the patient up under X-ray and see where the wire's at. Then if it's in the profunda, then it's, when you're trying to redirect it down the SFA, that's the time where you will be under fluoroscopy a little bit, so you need to be mindful of it. Sometimes switching out to a different wires. I've actually used coronary wires occasionally, where you can actually change the shape of the curve on the wire to kind of help you direct it. It can be helpful. And occasionally you'll actually need to take a puff of contrast down your needle to make sure you're not just stuck in the profunda. And no matter how much you manipulate the wire, it's not going to go up and over and into the SFA.
So you're not putting the micropuncture dilator in, you're just using a coronary wire through the needle. So you pull your 018 wire gently so we don't... okay, that's fantastic. I mean, obviously, if you have ultrasound expertise, some people like the longitudinal access and kind of using that live to redirect the wire, but it's pretty technically difficult, and especially with large groins, as you mentioned. So, and usually it's a case that's going to take a long time. So if you start stalling in your first part of the procedure, you kind of kill the momentum.
Yeah. I think your point, I'm not an expert at ultrasound at all. And me trying to do an echocardiogram is, I think people kind of get a good chuckle when they watch me try to do this. So, you don't have to be an expert with ultrasound to be comfortable with it. And I don't do a lot of longitudinal imaging. I know some people do. I'm not very good at it, but I think that's a great point, is getting better at doing that. And one of the things we talk about in the complex PCI realm and the CTO realm is purposeful practice, where you take things that you are going to occasionally need to do in an emergent setting, and you get practice doing them in a non-emergent setting. And so, the kind of the classic one in the CTO realm is learning how to use coils by coiling off a vein graft, or going and hanging out with one of your interventional radiologists when they're putting coils in a brain, just to kind of see how the coils work, so that when you perforate somebody and you need to drop a coil in somebody's coronary so they don't bleed to death, you've done it a few times. The same thing goes with access. A lot of newer trainees and newer docs, they learned radial. And I was fortunate, I'm old enough that I did most of my cases when I was training femorally, so I got more comfortable with that. But when you've done a lot of radial access, you may not have the degree of comfort with femoral access. And so, doing purposeful practice on cases where somebody has bypass grafts, just do ultrasound guided access to put your 6 or 7 French sheath in. Just make it a part of your routine practice. So then when you are in a more stressful situation, or in a situation that requires a little more urgency, it's not your first or second time fumbling around with a femoral artery ultrasound.
That's so true. And, for people who reach out for the ultrasound when they're really getting in trouble, when they can't get access otherwise with their kind of tactile feel and all of that, that's not the real good time to learn ultrasound. At this point, you've tried a few times, the groin is full of lidocaine, and usually it's a very difficult anatomy. So absolutely, can't agree more. And this obviously brings us to the basic principles of safe large bore access. So ultrasound all the way, 100% of the time, even in STEMIs, right?
Yeah, and I would say most STEMIs were going radial still. And the majority of our routine cases, PCIs, are still radial. Even CTOs now, we do most of my CTOs, I do radial femoral. But yeah, I think just gaining that comfort and not shying away from using femoral arteries is going to make it more comfortable when it comes to doing a more complex large bore access. The other thing is when I first started doing large bore access, there was a lot of anxiety about that. And so my first, 3 or 4 cases, I had one of my structural interventionalists come and do the cases with me, just the access and the closure, just because they had a lot more experience with that than I did. And so one of the things I've learned over the years is lean on people who are smarter than you, and lean on people that have more experience than you in a variety of different things. So, I work with my neuroradiologists, my interventional radiologists, vascular surgeons, my cardiac surgeons that have different experience in different things. And that's how I got good at it. The first time I learned how to put an axillary Impella in, first couple of times I did it with one of my cardiac surgeons who's vascular trained as well, and he kind of showed me the steps, and so lean on the expertise of people around you, and they'll it not only does it build good collegiality and camaraderie, they're also going to be the first one there to help you if there is a problem, and they'll be by your side. So it's a great way to learn is by bringing your friends who are better at things than you are.
And obviously, when you say ultrasound, of course, you're still counting on fluoroscopic guidance. It's the combination of both. And absolutely. Now, obviously, today's world is full of calcified and tortuous iliac arteries. So I'd like to pick your brain on what you do, and specifically, first of all, calcified artery access. Are you using your ultrasound to pick a non-calcified segment? And tell us
Yeah.
how you think about that.
Yeah, if you can. Sometimes you can't. It's hard to find a great spot, but yeah, I will scan up and down the artery and kind of see if I can find a soft spot that's still, in an adequate access area. And if it doesn't look great on one side, I'll look on the other side. I think that's a very reasonable place to start. So calcium is obviously seen a lot in these cases, but oftentimes it's not, necessarily going to impact our access site. So you can scan kind of up and down on the femoral artery and see if there's an area where that's potentially free of significant calcium. But a lot of times the calcium is not on the anterior surface of the artery where it's going to matter most to you. It could be on the side, it could be on the bottom. And so getting a sense of where it is, oftentimes you'll be able to find a spot that you can get in. And if you can't on one side, it's reasonable to then scan the other side and look for areas of calcification.
Excellent. How about tortuous iliacs? What is too tortuous? Is it a feel? Is it a 90 degree? Tell me how you think about that.
Well, I think this has kind of evolved for me a little bit and how I approach this. And a lot of it has to do with how a wire goes through it. So you can have somebody that has, fairly tortuous coronaries, and you drop a wire through it and it flies right up the artery and it actually straightens things out pretty easily. I don't worry about that. It's the ones that are real calcified, and you can't get just a regular J wire to go around those bends without, taking a microcatheter or catheter with it to kind of guide you all the way around. Those are the ones that are a little harder to straighten out. And so those are the ones that I'd be a little more cautious about using. The challenge though is if you think one side's tortuous, usually the other side's the mirror of that. So they're usually both tortuous, but sometimes you'll be able to find the one that's workable. I would say tortuosity is much less of a concern of mine nowadays. I'll be honest, I can't remember a case recently where we haven't been able to get it through even relatively tortuous arteries. And I know we'll talk about this later, but one of the things we'll use is the single access technique to deliver additional gear through to kind of help straighten out the artery and kind of make a path forward to get the device through. And I had my younger partner who was doing a case, it was probably about a year ago now. She was having difficulty getting anything to go around the bend, and she was about ready to bail. And I was like, all right, let's try a few things. And we were able to kind of work our way through it. So it's pretty uncommon now that we can't get something through the femoral arteries, even if they are pretty darn tortuous.
And obviously, equipment choice is so important for cardiologists who are mostly radial operators who don't have vascular experience. Tell us what catheters, wires, microcatheters you use sometimes to get through the tortuous iliacs, and what choices are kind of your number one and two.
I tend to use just I like the woolly wires or the VersaCore wire. It's a real soft wire. You can't hurt anything with it. And it takes the turns relatively well, and it's stiffer on the back end, so it does kind of straighten things out on the back end. So that's usually my first go-to wire. If I need to add a micro or a catheter to it, I'll use a variety of different things. I'll use 60 centimeter or 55 centimeter glide catheters. Sometimes I'll just use a JR4 coronary diagnostic catheter. Those oftentimes you're able to kind of turn them and point them in different directions to kind of help you through. That's kind of what I typically use. I'm curious if you do anything different, but
this hydrophilic coating of the glide. I mean, as soon as the JR4 starts getting stuck and not getting up there, as you mentioned, the hydrofilling, it's a purpose-built catheter for the peripheral vasculature, and the softness of the catheter allows to take a tortuous segment, and obviously, once you're up there, you exchange for a stiff wire. What's your favorite stiff wire for?
Typically, if it's just a routine case, I'll oftentimes use the stiff wire that comes with the Impella sheath, or otherwise I'll use an Amplatz wire. If I need something really big, occasionally I'll take a Lunderquist through, which is kind of like a coat hanger. It'll straighten anything out. So,
do you feel like it works against you sometimes when the wire bites? Yeah,
it can. Yeah,
Absolutely.
yeah.
So tell me about your thought process about using fluoro while advancing the large bore sheath. That's something that cardiologists are usually, it's not kind of basic skills and something that gets acquired with large bore experience.
Yeah, I typically will watch it go in. If there's any degree of tortuosity, I'm watching it for sure. If it's a huge artery straight shot, you probably that may be a little overkill, but I don't. It doesn't really cost you a lot to do that. It doesn't take any time really to do it, so I think it's a good practice to get into. One of the things that we didn't touch on with tortuosity is sheath choice. Obviously the Impella comes with both the large and the long and the short sheath. And when I first was doing the tortuous cases, I used to always pick the long sheath, thinking, well, that's going to kind of help keep things a little straighter, get me up to the bifurcation at least. But I've actually gone back to just using the short sheath. I almost never use the long one anymore. One of the issues we would run into is the sheath itself does not have a lot of radial strength to it. And if you get it in a real tortuous segment and you pull the dilator out, you'll get kinks in the sheath. And then it's really hard to get the Impella through, and you end up doing this kind of push-pull thing where you're having to pull the sheath out to kind of undo the little kink, and as you're pushing the Impella through. And so typically what I do is actually just put the short sheath in. That way you minimize the risk of the sheath kinking and having to pull the sheath in and out. And then I'll put the Amplatz wire that comes with the kit in, and then I'll try to deliver the Impella. Oftentimes it's actually the outflow cannula that gets caught on things and gets stuck. And that's the area where there's a little bit of a hinge point. And so if that's catching or it gets caught on an area, doesn't go through tortuosity, that's when I'll go in and do single access and deliver a second wire in to kind of help straighten things out or change the compliance or the anatomy of the vessel. And oftentimes that's enough just to deflect that area off of whatever it's getting caught on. The other thing is once you've got a wire through with single access, you can deliver other things over that wire. So I've taken balloons in, and so you kind of do like balloon assisted tracking to get it through tortuosity or past areas of calcification. So there are some other tricks you can use. So you can either balloon it to kind of modify a plaque, maybe that's it catching on. You can deliver wires through, or you can inflate a balloon in front of the Impella and then move them all together, like with balloon-assisted tracking. So it's just kind of one other way of dealing with tortuosity. So it's very rare that I use the long sheath anymore, because I've found dealing with the kinks is harder than dealing with the tortuosity oftentimes. And I'm oftentimes surprised. I put the wire across the Impella. It kind of looks funny making those bends, but it does pretty good getting through most tortuosity, really.
And the other aspect is the interaction between the guide and the Impella. That kink is also making the movement of your guide, if you're going back and forth and trying to move your guide, making very difficult.
Yeah.
Well, you just mentioned the single access technique, which has literally transformed interventional cardiology practice in the last 5 to 10 years. Obviously, everybody knows on the podcast is knowledgeable enough and actually practices that for high-risk PCI. But what you just mentioned are techniques to use the single access to get your equipment through the large bore device, through tortuous iliacs and through the aortic valve. So I'd love for you to kind of go back and tell us a little bit more about the technique that you mentioned about placing a balloon in the iliac. Can you go through that step by step?
Yeah. So, after your Impella's through, and now the entire body of the Impella has to be through. So you just have the shaft of the Impella in the sheath, because otherwise, if you don't, it's occlusive, and so you can't pass anything through. Once that's out of the sheath, though, you can deliver a wire through just like you would if you were putting doing single access to put a PCI sheath in. And so then you basically put an 035 wire through, and that can be used for dealing with tortuosity, delivering balloons to help deal with tortuosity.
You put a sheath in?
I don't. I just put the wire in, and then I put the balloon straight over the wire. It goes
over
right
the
through.
Wire.
Yeah. And it comes out very easily as well. You've obviously done a lot of single access too.
Mm-hmm.
That diaphragm on that thing, you
That's
can
phenomenal.
punish that a lot, and it just seals up every time. So that's really nice. And one of the things that we kind of earlier in my experience with Impella and using it in patients with aortic stenosis, we did a lot of BAVs before we put the Impella in. And I had a case maybe, I don't know, 7 or 8 years ago where we did a BAV, put the Impella in, started working on the coronaries, and the patient wasn't doing super well hemodynamically, and ended up getting a picture of the coronary, and I could see the contrast come back into the aorta and all was dumping into the LV. So what I realized is we had done a BAV, and we'd kind of torn open the valve and created a lot of aortic insufficiency. So the Impella wasn't giving us the degree of support we were expecting from it. And so that kind of really opened my eyes about being cautious about, doing too much to the aortic valve. I don't want to change the aortic valve. I just want to get my Impella in. And so if we have to do a BAV, which is very rare anymore, usually if the valve area is 0.6 or greater, you just don't need to BAV it. It'll go across. And so if it's really small, 0.5 or less, for sure, we'll oftentimes do a BAV. And when we do that, typically if I do it, I do a very small balloon. I'll do an 18 or 20 balloon. But the other thing that we've gone to doing is we'll oftentimes use a peripheral balloon and do it single access. So one of the difficulties if you're doing a BAV and then wanting to put an Impella in is the BAV balloons will go through the Impella sheath. So you'll go up, balloon the valve, and then you've got to leave a wire in, switch out a wire to the 018 wire, and then get the Impella in. But if you do it with single access, you can do it all through one sheath. So you get your Impella wire across into the ventricle. You then deliver, using the single access technique, an 035 wire, and I'll oftentimes get that in the ventricle, and oftentimes I'll switch it out even for like a Safari wire, which is, again, something I learned from my structural docs. It's a nice supportive wire, and it sits in the ventricle, doesn't cause a lot of arrhythmia. Put that in as well. So now you've got a Safari wire and the Impella delivery wire in the ventricle. And then over the Safari wire, I'll usually use a 14 by 40 or 14 by 60 peripheral balloon, put that across the valve, inflate it, and then as the balloon is deflating, I advance the Impella in. So the amount of time actually where you're worried because you're occluding the valve with a balloon, and between that and getting the Impella in and on can be within a matter of seconds. And so there's really very little hemodynamic impairment to the patient. And so that's kind of how we've gone to doing our BAV, kind of a mini BAV. Structural doctors would laugh at me if I said I'm doing a BAV with a 14 millimeter balloon, but it's all about just getting that device in, and it works really well. And so I'd use that a handful of times. It's a nice way of getting something in, getting it in relatively quickly, and getting a patient on support.
And so when you're inflating that balloon alongside the Impella shaft, do you see sometimes the balloon move with the heartbeats, or is that something you have to have rapid pace or no?
No, I don't usually rapid pace. You certainly can if you're worried about it. I will typically use initially I was using a 40 millimeter balloon, but now I've been using a little longer ones just because it tends to move a little bit less. And we haven't had any major issues with it. And again, if I'm worried about it, sometimes I'll have my structural colleagues come in with me because they have, more experience with, bigger balloons and rapid pacing and doing those other types of things. But usually it's kind of a quick balloon inflation and deflation. And oftentimes I think it's not so much that it alters the valve; it just kind of acts almost like a slide for your Impella to slide next to. It just kind of helps it avoid getting caught on little chunks of calcium on the valve.
And you said you sometimes even use a stiff wire as a buddy wire, and you advance the Impella. That the wire bias itself kind of pushes that aortic.
Yeah, sometimes it works against you, like you said. Sometimes it'll kind of kink the artery off almost if it's a real stiff wire. But sometimes it's enough just to get rid of some of the tortuosity or deflect the wherever the Impella is getting caught away from what it's getting caught on.
And let's say you don't have aortic stenosis, you have aortic sclerosis, which is obviously extremely frequent, and you're pushing that Impella and you're feeling some resistance through the valve on this relatively not very supportive 018 wire. It's supportive, but it's not the most supportive. Do you rotate the Impella around that? What do you do when you start feeling some resistance on the aortic valve?
Yeah, usually it's kind of a little bit of an interplay. Oftentimes you just give a little bit of backwards tension on the wire as you're advancing will help it go through. And so it's pretty uncommon that the cage of the inflow gets caught on the valve. And if it does, sometimes just adjusting a tension on that wire is enough to alter your angle that you're entering in with enough that it's able to go through. It's pretty uncommon now that we have a problem getting it across a valve. But there are those cases where it gets caught, but usually you kind of know about it ahead of time because they have some degree of aortic stenosis. I think the first case I ever did where I used this kind of single access technique to do it, I actually did a BAV. I think I used an 18 or a 20 and then I couldn't get it across. So I went back and BAV'd with a bigger balloon, still couldn't get it across. And so I knew it was something that was catching on my valve, was catching it. It wasn't necessarily an orifice area issue. And then we put in a 14 millimeter balloon across and did kind of the balloon assisted tracking. It sailed right through. And I said, all right, this is our new way of doing it. We're not doing big balloons anymore. And so we've kind of gone to doing that fairly routinely if we're thinking it's going to be a BAV assisted Impella delivery. The other thing is the nice thing about doing it kind of with single access is, you've got your Impella sitting right up above the valve with the wire across, and then you're not having to take all of that out and then recross, and then reintroduce everything again. And so, if I've got a valve that's, got some AS that's pretty significant and the valve area is kind of in that borderline area where like, hey, I may need to BAV at, like 0.6-ish or so, I'll oftentimes go in, get across the valve, put my Impella wire in, try to deliver the Impella. If it doesn't go, I just leave it sitting there and then I stick with a single access, get another wire across. You obviously need to take a catheter over that wire to help direct you across the valve, get across the valve, oftentimes switch out for a supportive wire. And sometimes just the wire alone is enough to alter the valve enough. And then I'll try to pass the Impella in again. If it doesn't go, then I take a 14 by 40, 14 by 60 balloon across and do kind of a balloon assisted tracking or a BAV and then advance it in.
So once the Impella is in, let's say in the rare circumstance where you need an 8 French guide for your complex PCI, are you using sheathless techniques with the dilator and guide, or are you sticking the other side? What are you doing?
I've done both. I've probably done, I've only done probably 4 or 5 cases where I wanted an 8 French guide in. And typically that's the left main trifurcation where you're potentially going to need 3 balloons in at once. But a friend, Stefan Renfray, he and I worked together on a paper where we described doing 8 French sheathless guide delivery. It works and you can do it, but if you have to do a lot of guide manipulation, by the end of the case, it's starting to get difficult to manipulate the guide. So, for example, the cases where you're tending to do some more guide manipulation is if you've got an ostial left main and you kind of need to back off the guide to place your stent or do imaging or whatever, and you're kind of going in and out with the guide starts getting really sticky after a while. And so it can be difficult in a longer case where you're having to do guide manipulation. If you're not doing any guide manipulation, you just get it in and let it sit there, then it works great. But the way we do it is we typically will use Cook makes a 110 centimeter delivery sheath, and we'll use the dilator from that 110 sheath with
French.
It's a 6 French. Yeah,
Excellent.
it's a 6 110 centimeter Cook flexor sheath, I think. And we use that dilator and take the French guide over that. We'll also fill the Impella peel away sheath with Rotoflush or Viper Slide, whatever you've got on the table. We'll fill it with that because it just kind of makes everything a little hydrophilic. The other thing that I like to do is the dilators that come with the Impella, I very rarely use those anymore because they've got that nice tapered dilator now for the sheath. But if you use those dilators, you actually push it through the diaphragm over the wire that you put in. There's a coating on those dilators, and it'll kind of rub off in that diaphragm, and it makes it that at least initially the manipulation a little bit easier. So we get a wire through the diaphragm. We fill up the sheath with Rotoflush or Viper Slide. I'll take that dilator through, dilate the tract, and then I'll take the long 110 centimeter flexor sheath dilator with the 8 French sheath and deliver it all up.
Jason, this is fantastic. In terms of limb ischemia mitigation, we talked about that with the antegrade access at the beginning. But tell us now, you're done with the procedure and the patient definitely needs support. The right heart hemodynamics are not good. You're keeping it in. How are you thinking about perfusing that leg?
I still think this is one of our bigger challenges with leaving large bore access in, specifically in Impellas. Typically we kind of talked earlier about how I like to kind of stick into the artery beforehand and get leave a wire in. That way I've got my access if I need to put an antegrade perfusion sheath in. But once you have an antegrade perfusion sheath in, you need to hook it up to another sheath to deliver retrograde blood into the antegrade perfusion sheath. Typically what we'll do is go to the contralateral femoral artery and place a retrograde sheath. And then we hook the two sheaths together with a male-to-male connector. This delivers blood, enough blood to usually prevent ischemia. But the problem and I know everybody deals with this, is they clot off. And it simply has to do with the hubs of the sheath, and the male-to-male connector is just smaller, and it creates, I don't know if it's just turbulent flow or just too small, but it creates areas where thrombus forms. So we're always thinking in somebody that is at risk for ischemia, obviously we want to put a perfusion catheter in, and we want to, in the short term, kind of mitigate that problem. But you're always going to need to keep a very close eye on your level of anticoagulation to try to minimize the risk of those clotting off. But we also have a very low threshold of getting the device out and moving it someplace else if we're having that issue. Because if you're having ischemia, it's going to be a continual problem until that device comes out, a continual concern. One of the things we've done at our institution is I have a very, very incredible, accomplished heart failure service and shock team, and our cardiac surgeons are extremely helpful in putting in 5.5s. I mean, they'll come in the middle of the night and do it for us if we need it. They're just awesome. And we've really gone to transitioning patients early to a 5.5 just because the vascular complications are so much less. And so, yes, you need to have strategies to mitigate ischemia and to manage it in the short term. But if it's a device that's going to need to stay in, on the order of days, one is you're going to get a whole lot better support, and you can have a slower wean of your support with a 5.5 in, and you're going to hopefully mitigate the risk of ischemic complications.
In those couple of days where, let's say, you did a external bypass circuit, do you have a specific protocol of PTT or ACT in the CCU, or you just keep a closer eye on what's your goal?
Yeah, so they typically will kind of run the PT. They usually follow PTTs in the ICU, and they'll typically run them, on the higher end, so 70, 80 or so. With everything, it's a balance, right? And so you're balancing the risk of bleeding. One of the things we've gone to as well is we pretty much always use bicarb for our flush now. And it doesn't mean that they're not on heparin, because obviously you're having them on heparin as well, but it's a lot easier to manage their anticoagulation with just a single drip of heparin, as opposed to balancing how much is going in through the purge if you're using heparin with the purge as well. It just makes it easier, for our pharmacists to manage that PTT.
Excellent. So you mentioned obviously this balance, and now we're getting into the opposite problem, the oozing around the sheath, and you're having problems with that. You don't have a major ischemia, or sometimes they happen together, but what are your tricks of avoiding oozing around the sheath in the CCU?
Yeah. So this was a huge problem for us and for everybody. And I remember, every time I pull a peel away sheath out and I push the repositioning sheath in, just like cursing under my breath, like, can't they make something better that doesn't do this? And so, I've tried everything. And the first thing you always do is you hold pressure and you see, and it looks like it looks better. And I've tried things like, mattress sutures or fem stops or things like that down in the ICU, and that doesn't work. It just makes a bigger mess. You just get these big hematomas. So one of the things I did for quite a while was we'd pre-close it and we'd pull on the pre-closed suture. And sometimes that would kind of tighten the knot enough around the arteriotomy that it would kind of control the bleeding. But oftentimes it was transient. And so then I tried things, sometimes, when you're pulling on the knot, it's catching on tissue and then there's the sheath there. So it's not getting down to the arteriotomy to really tighten it. So I try to take like the wire or the suture, kind of thread it through like a micropuncture sheath and try to use that micropuncture sheath to push the knot down. And that would occasionally work, but this was a common problem. But a couple years ago, one of the folks with Abumen, one of my local guys who always comes up with great ideas, Channing Wiles, said, "Why don't you tighten the per-close before you put the repositioning sheath in?" And I was like, "Oh, light bulb went off." So I did it, and I just take one of the knot pushers from the per-close, push the knot down, and then push the repositioning sheath in. Problem solved. Like, I have not had a bleeding issue since then. It works like a charm. And it doesn't, you don't lock the knot, so you can still use the per-close when you pull it out, but it just tightens it enough, and it's like solved that problem for me. So for me, a couple nuances with it. One is I'll take one of them and I push it down and then I put the device in. If it's still bleeding, and this occasionally will happen, I pull it back in and I push it down again and I try again. If it still doesn't work, then I usually push the other knot down. One case early when I was doing this, I tightened both of them down, and I tightened it so well that it was totally dry around the Impella shaft, and I didn't have my repositioning sheath in, and I'm like, oh. And then I went to try to get the thing in, and I had to work to get it in. I had to like kind of screw it to kind of get it in. I'm like, okay, from now on, I'm only going to tighten one. And so I don't do both of them. I'm still kind of a old school guy, I guess. I still use 2 per-closes. I know a lot of our colleagues have gone to using 1 per-close, and then when they take it out, they'll do the per-close, and if they still have bleeding, they'll put either a second one in or an angioseal in. I still do 2, but that's what we'll do is we'll tighten one of them down and put the repositioning sheath in, and it's virtually eliminated our issues with bleeding. Obviously, one of the concerns in doing that is if you're making the arteriotomy smaller, are you making the artery smaller as well? And is there an increased risk of ischemia? In our personal experience, I haven't seen that, but it is obviously a concern, a theoretical concern. But in our lab, nobody goes down to the ICU unless we've addressed bleeding and ischemia. And so we do that with the per-close, get the repositioning sheath in. We obviously are assessing for bleeding, but then the next thing that happens is they get an angiogram through the wire port of the repositioning sheath to confirm that there's no obstruction. And if there is, that has to be addressed in the cath lab before they go downstairs. And that's, along with all the other stuff. They don't go downstairs without a swan in. They don't go downstairs without a radial arterial line in. If needed a dialysis catheter or a cooling catheter or whatever, I don't want to have anybody sticking lines in the patient downstairs. That should all be done in the cath lab before they go. You'll make your ICU docs and your heart failure docs a lot happier with you if you send them a terrible patient well packaged.
And when you said tighten the suture, just a technical kind of note on that, you're basically pulling the non-locking suture.
Yeah.
You're not tightening the knot. You're just pulling the non-locking suture up, and you're pushing that knot pusher down.
Pushing the knot down onto the arteriotomy. It tightens the knot. It does not lock the knot. Yeah.
Excellent.
Yeah. And right. If you don't lock it, then you can still use it when it's time to get it out.
And the thing that did it for you is to do it before you do the repo sheath. When you do it after you put the repo sheath, it's not as effective.
Yeah. We've done it now for a year and a half, 2 years, and the bleeding issue has gone away for us. It's really been a game changer. The other thing that occasionally comes up is, we're a tertiary referral center like you guys are, and we occasionally will get somebody transferred in that had an Impella placed emergently and they didn't pre-close the artery. It happens. And it's happened to us too. You're in an emergent situation. You don't have time to be elegant with your pre-close. And so how do you manage that oozing groin den? And my former partner, Ethan Korngold, kind of came up with a brilliant idea. And he and I wrote a paper a couple of years ago called the Sideclose Technique. And so essentially with this, you've got your Impella in, you've got your repositioning sheath in, it's bleeding around it, and you don't have a pre-close. That's the problem. So what we'll do is, and this is a two-person job because they do tend to bleed a lot, you have somebody kind of managing the groin and holding pressure. The operator then undoes the sleeve, the protective sterile sleeve, and then you take out the obturator in the wire repositioning port. You put a wire up, and then you walk back the repositioning sheath. So now the wire is sitting to the point where you can actually see the wire and the shaft of the Impella together. You then take the wire and pull it out from the wire repositioning port. So now you've just got a bare wire sitting next to your Impella shaft. You then use that wire to do a perclose. And so you perclose right next to it. And essentially what you're doing is you're taking your arteriotomy and you're closing one side of it. So you're making it smaller. And then when you enter, you pass the repositioning sheath back in, you get hemostasis that way. So it's a way to introduce a perclose if it hasn't been pre-closed. Don't have to do it very often because, again, we're pretty, even in sick patients, if I really try to get one perclose in just because it saves me a lot of time. But it's a great technique if you've put a device in and you haven't pre-closed it.
Fantastic. Just because obviously most of our listeners are on audio and there's no visual behind it. So basically you are pulling the repositioning sheath of the Impella shaft alongside another wire through the wire port, and then you're pulling the proximal component of the wire from the repo sheath out so you can free it up and you can use it.
Exactly.
So you have a body wire next to the Impella shaft, and now you're going to pre-close. And of course, the arteriotomy side. Are you worried about the needles of the perclose not catching on the Impella shaft itself?
Yeah, usually once you pull the foot plate back up to the arteriotomy, it's well away from the needles are on the outside, obviously going towards the artery. And if you pull back, the foot plate should be up against the artery wall. We haven't had any issues with hitting the Impella shaft, but this is kind of one of those scenarios where you really want to try to keep the Impella shaft and the angle of entry of the perclose parallel to each other to potentially minimize any risk that your foot plate will actually grab the shaft of the Impella. Haven't had any issues with it. The biggest issue with it is just it's kind of it's bloody while you're doing it. So it's really helpful to have a buddy there to hold pressure while you're doing all the manipulation that you need to do. But it works very well, but it is a little bit messy to do it. It's just there's a lot of bleeding in it. But we haven't had any issues in the 8 or 10 cases we've done of hitting the Impella.
And what would you say for the people who solve the bleeding issue by keeping the peel away sheath in? I know obviously it's a thrombosis risk, but do you recommend that, or is that a bad idea? And if you do, would you go up on your PTT goal?
Yeah, we don't routinely do it. I remember, I don't know, it was probably 5 or 6 years ago, I had a case where I wanted to leave it in to be my delivery sheath, my retrograde sheath for delivering into an antegrade sheath, and got in a lot of trouble from my ICU staff about leaving the peel away sheath in. And so we don't routinely do it. I know there are colleagues of ours who do routinely use that. I think there's some theoretical risks of leaving that sheath in. It's not the most stable sheath. It can tear, it can kink. And it's big, so it's occlusive too. So, there are some issues potentially with it. I know Abum has been working on a new sheath to hopefully be able to use just a single sheath and not use the peel away sheath. They can hopefully make it a little smaller so you kind of don't have as much of a risk of ischemia, but there's still going to be that ischemic risk with it. If you're leaving that sheath in, and you're using it as your retrograde part of your perfusion catheter, then you don't really have to worry about the thrombus risk. If you're leaving it in otherwise, I don't know the reason why you would do that. I guess because you're right, it's just a dead space that will thrombose. And so if there's any manipulation of the Impella, there's a risk of passing clot out. We've had several cases over the years where we put in Impella's axillary, and the patient needed a TAVR. So the Impella comes out, they get the TAVR, and they want to put the Impella back in and advance clot, and that can be devastating. So, leaving a peel away sheath in, I just think the risk is probably more than any benefit, unless you're needing it for the antegrade or retrograde perfusion limb. And then because you've got blood going through there, there's a lower risk, I think, of thrombus. But yeah, I generally try to avoid doing that, leaving the sheath in.
So we're getting to the closure part now. So you have a single access, you finished your PCI, great result. The right heart is good. You're pulling that right heart catheter out if you have to, unless heart failure wants it in. And now you want to close. Tell us about your dry closure techniques.
Yeah. So I'll be honest with you. I don't do it a whole lot. I do the majority of my cases single access. So one of the disadvantages of single access is you don't have the second access to do, contralateral dry closure or post-procedure angiography. And I know there's some of our colleagues who are big advocates of that. And I think, I can't argue with it. There is a degree of safety with that. But, from the data we do have, we know that single access probably lowers the risk of bleeding. There's going to be some more data coming out on that hopefully soon, and may decrease procedure time too. But one of the downsides is that, you don't have the ability, the ease of managing a complication because you don't have the second access in if you happen to have one. And so, you and I worked on this. We developed a technique of doing a single access dry closure. And so with that, the Impella comes out, you've got the peel away sheath in still. Yeah, you leave a wire in through the peel away sheath, and then over that wire, you deliver an occluding balloon for the iliac. It's usually a 7 or an 8 millimeter balloon in most patients, based obviously on the size of your pre-procedure imaging, getting a sense of that. You deliver that up into the iliac system and then inflate that to a nominal pressure. At that point, then you remove the peel away sheath and then tighten your pre-closed sutures. At that point, then I'll release the balloon, take the air out of the balloon, and look for any bleeding. And if there's bleeding, you can either retighten the sutures and see if you can control it that way. Occasionally, you need to take the balloon out and deliver a second and or third closure device to see if you can get it closed that way. If it's a vessel that still is having persistent bleeding at that point, you could potentially reintroduce the balloon, inflate it, and kind of buy yourself some time until you get a second access to potentially deliver a gear or balloon, or worst case scenario, even a covered stent or something to manage that groin. I don't do that routinely. And the times that I've done it is generally in patients who I think have a greater risk of bleeding, patients that have a lot of vascular disease, patients who, when I go to do my pre-closes, I've had to use 3 or 4 or more per closes because it's just not taking, the suture's not taking. Those are the ones that I have a greater degree of concern that I'm going to have bleeding issues. And so those are the ones where I have a low threshold to put a balloon up and do the single access dry closure. But those are also the cases that, oftentimes you're worried about. So those are the ones that you're getting access in on the other side anyway, because those are the ones that you're thinking, hey, this could be a problem. One of the nice things about femoral artery access, though, is it's generally easy to manage with manual pressure. And so I get a reasonable closure. A lot of times I'll just do, an extra 10 or 15 minutes of manual pressure, and that's good enough. But if you're really worried about it and you want to do an angiogram, there is a way to do kind of a single access post-closure angiogram. And typically what we'll do is we'll have a wire in, pull the peel away sheath out, deploy the per-closed sutures. If you're still worried that there's a lot of bleeding, I'll introduce a 4 French sheath over the wire, and then take the wire out and then do an angiogram through that 4 French sheath and look and see if there's any significant bleeding. If there is, obviously at that point, then, you either put a wire up, a balloon up to kind of tamponade it, and then you're starting to think about getting alternative access to get into to deliver something to hopefully manage it. But it's kind of a way to do a post-procedure angiogram without having a second access point.
Excellent. And that obviously leads us to closure. You told us you like the 2 pre-close. Do you have alternatives? Do you think about alternatives? And what have you seen from the community in terms of preferences?
I think a lot of people, from what I hear, are going to using just a single per close. If that alone doesn't do the trick, then adding an angioseal. People tend to like that. I think that's great. It's one of those things that I think I still do the 2 per close, and it works for me. And so I think if you find something that works, you kind of stick with it. And I haven't found a real compelling reason to switch for myself. But those are the ways that I think most people are doing it. I don't have any experience with Manta. I don't have any experience with it. I know our structural team had evaluated it, I don't know, 5-6 years ago. They didn't necessarily find where that fit in for them. And, I've been doing per close since I was, for 20 years now, and I certainly have a lot of comfort with it. And so I've kind of sticking with the thing that works for me, I guess. Curious if you do anything different.
I love the angioseal per close combination. Obviously, 2 per closes work perfectly well. What I found is sometimes retrospectively, there's a semi-stenosis, which subsequently usually resolves. But I like the combination of the cinching down of the artery, then the angioseal lifting up that artery with they're kind of complementary, and it's worked for me, especially the 8 French angioseal. It kind of plugs up a lot, but of course there are a lot of variations. Some people have used minks after 1 per close. Obviously, it adds a few more steps. On the horizon, are you seeing any large bore closure devices on the U.S. market making a major entry? Are you optimistic, or you think traditional way is working? Let's stick with that.
I'll be honest, I haven't heard of anything myself. You may have. I know there was a per close device for larger bore, specifically made for larger bore. I haven't seen any news about that recently. Back when I was in my training, I know there was a large bore one, and it was fairly cumbersome, and we seemed to have pretty good success just with the regular one. Have you heard of anything else?
No, the PerQseal, I feel, has a potential, but obviously a lot of our European colleagues have been using it for a few years, so maybe this will cover an unmet need. And the other issue I'd like to get to before we conclude is the alternative access. You mentioned axillary a few times. So when obviously you're looking at the anatomy, if the iliacs are occluded and non-fixable, of course, that's kind of a slam dunk for alternative access. But when do you decide this is not a femoral access, I'm going to move on to either something else, and tell us how you think about that?
Yeah. Well, I think our feeling of axillary access has definitely changed over the years. Initially we did it when there was a lot of tortuosity or a lot of disease in the iliacs that we thought it might be prohibitive, and so we used it a bit more, 4, 5, 6 years ago. The other reason we were using it more back then was this was pre 5.5 and really before our surgeons got very, very good and comfortable with throwing in axillary conduits for 5.5s. Our heart failure team used to like us to put the CPs in axillary in patients that were going to be on support for a period of time, 4 or 5 days or more, because they could ambulate them, they could sit them up. And some of the reasons why we like 5.5 now, obviously. And so we were doing a bit more of them back then. But I think things have kind of changed over the years. One is just the degree of safety with putting in a 5.5, and the degree of support that you get from it is just way different. It's a better device for these long-term devices, heart failure patients. And then the other thing that's kind of evolved is using shockwave facilitated femoral access. It's a pretty safe atraumatic way to treat a calcified stenosed femoral artery without needing to come back and put a lot of stents in. So our colleagues that maybe don't have as much experience with peripheral vascular interventions, techniques, et cetera, it's a nice way to kind of deliver a device relatively safely. So because of that, our axillary usage has dropped. The other issue is, the axillary artery with the repositioning sheath in our experience, if it was in for a longer period of time, 4 days or more, we were seeing a lot of thrombus form in them. And, the arm is quite resilient. You can put a lot of thrombus in it and it actually does okay. And so you can kind of manage them conservatively oftentimes. But it's a little unnerving to have to leave thrombus behind. And so I think we do a little bit less axillary, but there are certainly those cases where you just need to do it. If somebody has just terrible aortic disease or an occluded aorta, you just don't have a choice. And so, I probably do 1 or 2 a year now.
Left axillary, right axillary?
Both. A lot of times we've done a diagnostic coronary angiogram, and so we've gone through the right radial artery, so we got a sense of what the anatomy and tortuosity is from the right side. But we'll go through both sides. The left side's a little more predictable as far as its path, and you're a little less likely to deal with tortuosity. But I also like doing the right side because then it's a little more ergonomically easier for me to do single access axillary PCI from the right side than the left. If you do it on the left side, you typically I'll use a long sheath. Oftentimes I'll use even a 60 millimeter, like a pinnacle destination sheath, and have the sheath actually drape all the way across the patient. But again, just from the PCI standpoint, it's a little easier doing the single access from the right side. So we still do a lot of them on the right side as well. Occasionally you'll get in and you're not sure. And so typically what we'll do is we'll go in if I think I want to use the right side, but I'm not sure if there's going to be too much tortuosity. I'll get radial access on the right side, go up, take a axillary angiogram just to make sure the artery's, adequate. But then just kind of watching the wire travel into the ascending aorta and what path it takes. And if everything wants to drop down the descending aorta, you're going to struggle getting your Impella in. There are ways to mitigate that. We talked about using single access to deliver other wires and equipment to help kind of get your catheter around the bend into the heart. You can do that. But again, if I'm having to work that hard on it, why don't I just go to the left side and not have to worry about it? But these techniques are helpful. I've had to go help my surgical colleagues a couple times where they've put a conduit on and then they can't get the 5.5 around the tortuosity. Well, the 5.5 Pella goes through a sheath that's exactly like the CP sheaths as far as the diaphragm, so you can do single access through that 5.5 sheath. And we've done this a couple times with our surgical colleagues where we've had to deliver wires across to kind of straighten things out, deliver balloons to kind of help us balloon things in. And so those techniques can be used, and it's a good way to kind of help your surgical colleagues and show them some new wire skills and new balloon skills. They like it.
Fantastic. And, obviously you mentioned one ergonomic tip is when you're standing on the right side and you got axillary access on the right and you're using single access, you're pulling probably half of your long sheath out of the body so you can stand in your usual position.
It's just like doing a radial case, yeah.
Perfect. And just a couple words on in terms of your technique of getting axillary access. You said you get an angiogram. Tell us the landmarks that you think. It's a big topic, but just a couple of things on that and on the Sideclose technique and the axillary. What specific recommendations you have with that regards?
Yeah, you bet. So we always start by getting radial access on that side. It's important to go in, to deliver a wire, like I said, to kind of determine the path of the vessel, to do an angiogram to make sure that the artery's not, tiny or there's not, obstructive disease there, which is rare, but occasionally you'll see it. But it's also nice to kind of get a picture and look for any vascular anomalies or side branches that you need to be aware of when you're getting access. At that point, then, we put the patient under x-ray to kind of get a sense of the bony landmarks. And so you're looking kind of at two things. One is you leave the wire across, so then you know the path of the vessel. And then you're looking at the humeral head and you're looking at the chest wall. And we're kind of sticking almost between those two. The closer you get to the chest wall, there's always the risk that you actually enter on the inside of the chest wall, and then you've got an artery that you can't control if there's bleeding. So you obviously need to be outside the chest. But if you are closer to the chest, centimeter, 2 centimeters away from the chest wall, it's actually a real nice bony prominence that you can hold pressure against. You just pin the artery up against the second rib. So you actually can hold manual pressure on some of these if you have a little bit of oozing. If you go a little too far distal, like down near the femoral or the humeral head, you start worrying about the brachial plexus at that point, because the axillary artery is kind of broken down into 3 segments. When you get down to that third segment, the most distal segment of the axillary artery, the brachial plexus nerves rotate up above on the top of the artery, and so there's a theoretical risk of injuring the nerve. We haven't ever had any issues with that, but that's a risk. And so I typically like to have my access site about 2 to 3 centimeters outside of the second rib. And so what I do is I put the patient under x-ray, I identify the bony landmarks, and then I take my calipers and I kind of put it right over the spot I want to enter the artery, and right over the wire that you see under fluoroscopy as well. I then pull the patient out from under x-ray and I put my ultrasound right over that spot. And then I find the artery. The nice thing about having the wire in is that you can tell which one's the artery and the vein, et cetera. And then we use that as our marker, and then we do access very similar to the way you would do ultrasound-guided access in the femoral artery. The one exception is your angle of entry has to be a little bit shallower when you're going axillary. Typically in the femoral artery, we're going in about a 45-degree angle. When you're going in axillary, that artery actually kind of curves and kind of dips down as it's coming out of the chest. And so if you go in at a 45-degree angle, you're actually hitting the artery at about a 70 or 80-degree angle. It's almost coming in at a right angle. And so if you go in at about a 30-degree angle, you get a little bit more favorable entry site, and then you're less likely to have kind of kinking of the artery and bleeding afterwards. The times we've had bleeding from our axillary arteries is when I go in too steep. And usually when I go in too steep, it's because it's a really big patient. And, you kind of have to go at a steeper angle just to get to the artery. But those are the times where you worry about it. And then you put your ultrasound right where you want to enter. You numb up the area, you make your skin nick, and then you enter with your micropuncture needle at a 30-degree angle. And you really want to watch the needle hit the artery. And if you see the needle hit the artery, you're generally going to be happy with where you went in. I then enter with the micropuncture wire, and then at that point, I put the patient back under X-ray and I check to make sure that it is exactly where I want to be before we do any dilating. And then at that point, you're just dilating it up, delivering a pre-close, and getting to work. Typically, I've always done 2 per-closes in the axillary artery, but again, I think other techniques certainly would be reasonable as well, but I still do 2.
And tell us about your pull force on the per-close in the axillary artery and the difference between that and the femoral artery.
Yeah, so the same thing, with the angle of entry, typically when we pull back on the per-close in the femoral artery, we're pulling at about a 45-degree angle. And this one, you'll have a little bit shallower angle, but you also don't need to pull as hard. It's not as maybe a robust of an artery as the femoral artery is. And so you don't want to, damage the artery. So you don't necessarily need to pull hard. Just pull back till it stops bleeding, and you don't really want to tent it too much.
And obviously with this shallow angle, you end up in most patients entering the skin almost 3 to 4 centimeter distal to where your ultrasound is sitting. And the advantage of the ultrasound is to avoid the veins. And sometimes, I found that you can actually identify some nerves on top of the artery, like bunch of grapes that you can sometimes avoid sticking. So
well, you're obviously way better at ultrasound than I am. So.
I just learned it. I've never been trained ultrasound like all of us, picked it up in practice. And a final word on a carotid access. Do you still use that? Is that a collaboration with vascular surgery or cardiovascular surgery?
Yeah, I don't. We don't use it that way. It's funny, we've talked about it for years, and we're always anxious to do it. But our structural program, I think, has one of the largest case volumes of transcarotid TAVRs. Really just kind of pioneered that. Eric Kirker, one of our cardiac surgeons, who's also a vascular surgeon, incredible operator, and Ethan Korngold, one of my former structural partners. They really led the way in this field, and so they just have tremendous experience with it. So Kirker and I have always talked about doing a transcarotid high-risk PCI. We've just never needed to do it yet. We're between better techniques with femoral access, shockwave facilitated femoral access, axillary access. We haven't gotten to the point where we needed to do it, but I know it's been described, but I haven't done it myself. But fortunately, I have the right colleagues if I would ever need to do it. But it does need to be done in conjunction with a vascular specialist, either a vascular surgeon or CT surgeon that has comfort with it. Obviously, the concern with any time you're doing the transcarotid is the stroke risk, but our team has published on this, and their stroke rates are exceedingly low. So.
Well, this has been a whirlwind tour de force on large bore access and closure. We can't thank you enough for all these beautiful tips. And do you have any final words for cardiologists who are making the move to large bore? And you had mentioned a few helpful in terms of how to make that move and how to surround themselves with support.
Yeah, I think probably the best thing to do is to practice in non-urgent situations. Obviously there's, a lot of interest because of the DanGer trial about the use of Impella hemodynamic support devices in shock. I think it's important, but that's not always the easiest place to learn to put in large bore sheaths. So learning it in a high-risk PCI scenario is the best way to learn it. But start with the fundamentals, best practices of, micropuncture, ultrasound guided and fluoroscopic guided access on a diagnostic cath that you're putting a 5 or 6 French sheath in. Practice on those cases. When you're going to be doing a large bore case, hopefully you've had some time being with a mentor and seeing how they do it. And then have those colleagues that have more experience with large bore access. Have your structural docs come in with you. Have your vascular surgeons come in and help you out. It's obviously best for the patient because you're doing this with somebody who has experience with it, but it also builds collegiality and camaraderie. My vascular surgeons, it's a lot easier to call them at 11 o'clock at night when I've got a complication, when I've worked with them before, and they know who I am, and they know that they've taught me these things, and they're much more willing to pick up a phone and come in and help. The last thing is lean on the experience of others. Our surgical colleagues, our interventional radiologists, our vascular surgeons, our structural doctors. Oftentimes they'll have a lot more experience with large bore access and troubleshooting and complication management than we do. And so learn from them. And that way, there's a team of you taking care of the patient and making sure that these procedures are done as safely as possible.
Fantastic. On that, I'd like to thank you on behalf of the BackTable Podcast team. And this has been wonderful, and we'll have you back pretty soon. So get ready.
Sounds good. Great to be with you, Hady.
Thank you so much for joining us on BackTable Cardiology.
If you have not already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend.
If you have any questions or comments, direct message us at _BackTableCards
on Instagram, LinkedIn, X, TikTok, Blue Sky, or YouTube.
BackTable is hosted by Hady Lichaa
and Sami Seifo.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for tuning in.
We'll see you next time.